Good morning, everyone. I hope you all had a good rest of the day yesterday. We're going to continue this morning talking about relationship-centered communication and particularly the patient-centered interviewing skills that we use to create or allow for relationship-centered communication. But as we did yesterday, I'd like to sort of spend a moment for us to get body and mind and maybe even spirit in the same room at the same time together. So if it feels comfortable to you, I'd like to invite you once again to sit back in your seat, uncross your legs, find a comfortable place for your hands, gently close your eyes or soften your gaze, and just listen for the sound of the bell for a moment, noticing that it arises, it persists, and then it decays. And now from sound, I invite you to bring your awareness to your breath, just following the wave of the breath without needing to change it in any way, simply using the breath as an anchor for the awareness, the breath that you always have with you, and you can access anytime the going gets rough. Just find the breath, which is here and now. Noticing distractions, coming back to the breath over and over as needed. And perhaps setting an intention for the rest of your day today, perhaps to work hard or to be the best doctor you can be, or to be more patient or more joyful or more grateful, something like that. Whatever you think you could carry on for throughout the day today. And I invite you to take a deep cleansing breath and open your eyes, and we'll continue on with our morning together. Thank you for playing along. All right, so a brief review of what we talked about yesterday, just to ground us on what we'll be talking about today. You remember yesterday we talked about how we start the interview by setting the stage for the encounter, by creating rapport quickly through reading, using names, sitting down, things like that. And then developing a shared agenda, recognizing that my agenda as I walk into a hospital room or a clinic room is only one agenda in the room. And if I think it's the only agenda, I'm really setting myself up for a suboptimal encounter. The patient brings their own agenda into the room, which often doesn't completely match, sometimes doesn't match at all with my agenda. And we need to understand both agendas and navigate those, right? And today we're going to talk about these patient-centered skills that allow the patient to tell the story of their illness, which serves three important functions for you as a doctor and for the patient. For you, you will get diagnostically important information that you will not get through only closed-ended questions. All right, when did it start? Where is it located? What makes it better? What makes it worse? You won't get the information this way. The other thing is that the patient will have the cathartic experience. They're telling a story they've been dying to tell someone who cares about what's been going on with their body or their mind. So that cathartic experience is incredibly therapeutic. And it builds this relationship of trust that will decrease your risk of medical practice suits, make your patients love you more, increase your stars on your patient satisfaction scores, et cetera, et cetera. So really helpful to use these skills. But then, of course, step 5, which we'll talk about, is just a transition to that middle of the interview, right? Where you're going to ask whatever onset, position, quality, radiation, severity questions you need to complete the story of the history of present illness. But you'll have fewer of those questions to ask because the patient gave you spontaneously many of those details just in the telling of his or her story. Okay. And then we talked about remaining patient-centered and then doing the physical exam and ending the visit. Someday maybe I'll come back and we'll talk about ending the visit, but not this week because we just don't have time. So we'll focus on the red part of the interview this week. Okay, so remember at the end of step 2, we've arrived at a shared agenda for the visit, and we've determined which item we should start with, which item might be identified as the chief concern of the patient. And by the way, we used to call that chief complaint in medicine, but that's really a pejorative term. Right? I've actually heard patients say when there was a bedside presentation, the patient's chief complaint is abdominal pain. And the patient says, I'm not complaining, it hurts. So complaint for the patient means something different than complaint for the doctor. All right. So now we call it chief concern because that's a more accurate and less pejorative term. So the chief concern is the thing we start with. And it may not be the first item the patient mentioned, and it may not be what the nurse tells you they're here for. That's why step 2 is so important. So, how do we draw this story out? Well, we begin with what I like to call non-focusing open-ended skills. Uh, they're really mostly attentive listening skills, and they're mostly being quiet, uh, letting the patient talk. You might think of them as the Starbucks skills. You know, your friend wants to meet because they had a breakup, and you have a coffee together, and your friend tells the story, and your job is mostly to nod and lean forward and to stay engaged and go, ooh, wow, hmm, right? And that's what draws your friend's story out, right? Yeah, great. So, what are these skills? Well, as I mentioned, silence, and as I demonstrated, non neutral utterances or continuers rather. And then there's this nonverbal encouragement, nodding, eye contact, smiling perhaps, even a hand gesture like this will encourage the patient to say more. Right? These are all tools in your tool belt that you can use as appropriate. Silence is the hardest one for medical people to practice. We hate silence. I think, it feels like if there's silence, this date's going really badly. It feels uncomfortable. But silence can deepen a relationship. And there is actually research that shows that patients can easily tolerate 4 seconds of silence before it starts to feel a little bit psychiatric, or creepy. The research also shows that clinicians can only tolerate 2 seconds of silence before they start crawling out of their skin. So all we have to do is make ourselves comfortable with to 2 seconds more. And in my practice, I would kind of surreptitiously time this sometimes just for fun. And the longest I've ever had to wait is 2.5 seconds. So you don't have to extend your 2 second comfort to 4 seconds. Really, if you could just get it to 3, that'll be good enough. And when you stay silent after a patient stops talking, what they will tell you when they start talking again is exactly what you needed to know to figure out what's going on with this case. So it's very powerful silence. Uh, so what you're doing here is you say to the patient, tell me about this back pain. If the back pain was the most important thing you identified in step 2, start at the beginning and bring me up until now, you might say, because you're asking for a chronological symptom narrative. And then you use these powerful, non focusing, open ended skills to hear the symptom story. And what will happen in this part of the interview is the patient will put things on the table, if you will. Okay. So, because you told them to tell you about the back pain, they'll start telling you the symptom story of their back pain. But if you listen carefully, almost everybody will also tell you something about the personal story or the personal context of this illness experience. And that's because symptoms don't live in a vacuum. Patients don't live in a vacuum. The back pain might be affecting the person's ability to do their work. That's personal context of the back pain, right? And it might even be the fact that the guy can't work that made him come to see you for the back pain, right? If he had a desk job, maybe this back pain wouldn't be something that he'd go to the doctor for. But because he works on a loading dock, he has to come to the doctor because it's affecting him. So this deepens the story. And my experience is in step three, about 50% of the patients will also tell me how this is making them feel, either the symptom itself or its impact on their life. And that, so you get the emotion just with using these skills about 50% of the time. And I'd say about 80% of the time, patients spontaneously tell the personal story. This doesn't last for very long, okay? It lasts for maybe half a minute, sometimes 15 seconds, maybe a 60 seconds if the patient really can provide a good narrative, get things going, okay? But I'm not saying never open your mouth, okay? You've got important questions to ask and tasks to do, but start here with some silent, attentive listening, okay? Um, and while you're listening, pay attention to this person in front of you, this patient in front of you, and see what you can learn non-verbally. So, for example, what's this patient perhaps feeling? Just make some guesses. Anxiety? Huh? Closed off. Yeah, yes, sir. Huh? Unsure. Yeah. Any other guesses? These are hypotheses, right? This is a differential diagnosis of what we're seeing, right? What else might she be? Huh? Embarrassed, nervous, maybe depressed, maybe cold. You don't know, right? We don't know, but something's going on. And that's what makes medicine so exciting. Something's going on, and our job is to help figure out what it is and to be of service there. Okay? So, very easy to develop this muscle of noticing deeply what's happening to this person in front of you. So, nonverbal cues, super important. Other things you can look at are physical characteristics. I remember making the diagnosis of Graves' disease from like walking the patient from the waiting room to the office, just looking at this patient with a goiter, thyroid stare, kind of shaky, sweaty. And I said, this person has Graves' disease. And sure enough, they did, but it took about 1 second. And that made that diagnosis. And that'll happen a lot. Maybe you'll notice a nicotine stain, between the thumb and the first finger or the first and the second finger. So this person's clearly a smoker, or you'll smell it. Maybe somebody's got tremor. Maybe somebody is pale or flushing. Uh, Autonomic changes, talking about flushing. Sometimes people will suddenly blush or blanch while talking, and you have to say, why is that? Why is this person having an autonomic response while telling this story? Are they embarrassed? Are they frightened? What's happening? You've heard maybe or read in books, and the color ran out of her face, right? That you'll see that in real time sometimes, where the person just gets pale just from, or maybe they're about to faint, but maybe not. Maybe it's also just something about the story they're telling that's creating an emotion that you can actually see. Accoutrement, in the outpatient setting, accoutrement are the sort of things that people wear or have with them that tell you something about them. Maybe it's a ball cap with a team emblem, or maybe it's a wedding ring, which may or may not mean the person is partnered, right? Might mean they just don't want to get hit on every night, so they put one on. But it says something about the person, right? Or maybe there's a rainbow flag on their backpack, and they're telling the world that knows that they're a member of the LGBTQ community, right? So these things are really, really helpful to notice. And then lastly, the environment. Now, this pertains more to the inpatient setting, right? Where you can see what people are reading, maybe what they've been eating, whether there are flowers, whether there are get well cards. If I walk into a hospital room of a patient who's been there for 2 or 3 days and there's not a single get well card or bouquet of flowers, that's an automatic consult to social work, because this person has nobody out in the world who seems to care that they're in the hospital. So who's going to help them when they leave the hospital, right? So these little things are super, super important. One of my favorite things when caring for a diabetic patient who's out of control in the hospital, where we're really trying to figure this out and have them on the correct diet and stuff is to look in the trash can and see the Kentucky Fried Chicken box from last night. It just gives you a clue, but that's something that is available to anybody who wants to pay attention, right? In the service of that patient, not as a gotcha, but just how can I help? What's going on here? So, oh, and then the last thing you should pay attention to while you're deeply listening to this story is yourself. How am I feeling while this person is talking to me? Do you ever think about that? Maybe you've noticed it, right? Have you ever had a feeling? I mean, I've interviewed patients or, listened to them, and I just find myself, I'll be sitting here listening to them as they're telling their story, and I just find myself doing this. And I start thinking to myself, Fortin, maybe you should have gone into real estate, or I don't, get it. Is this a midlife crisis or whatever? And then I realize, oh my God, I'm fine. This patient's depressed. It's not me. Depressed people make non-depressed people feel depressed. Anxious people make non-anxious people feel anxious. People who are suffering with borderline personality disorder make people who don't have that want to leave the room, want to flee and run away. It's so notice what gets triggered in you when you're interviewing the patient. These are super powerful things. And this is what separates good physicians from excellent physicians is the capacity to use all these data streams in the service of the patient. And each of them takes some work to hone and develop, but you all have that capacity. So let's find a partner. And if you don't have a partner, raise your hand. Everybody got some? You need somebody? Is there anybody who doesn't have a partner? You guys partnered, everybody? Okay. I'm going to be your partner if you don't mind. Okay. Don't get stressed. It'll be fun. Oh, here's someone's coming in. I don't know if they're a student or are they a student? Yeah. Miss, I, would you mind coming down here to partner with this young woman who's raising her hand? Oh, she's going to be your partner? She didn't raise her hand. I didn't know she didn't have a partner. Okay, she's got one now. Do you need a partner? Oh, come on down. Come on down. You guys can talk. Okay. So, what I'm going to have you do is you're going to be in two different roles, okay? So 30 seconds at a time. Decide who's going to be the speaker first and who's going to be the listener first. When I ring the bell, the speaker is going to talk about a vacation they took recently, what they did last weekend, something like that for 30 seconds. And the listener's job is to use only the open-ended skills we talked about: silence, nonverbal encouragement, and continuers. Okay. And then I will ring the bell and you will switch for 30 seconds. Okay. So this isn't going to take too long. Let me just get my stopwatch going here. All right. So just determine, don't start talking yet, but determine who's going to go first. Okay. And then, okay. You all ready? All right. Begin. Okay. Switch, switch. All right. We'll stop. Good. Thank you for playing along. Let's debrief this little activity. Okay. So when you were the storyteller, you each had a chance to be the storyteller. What was it like to tell your story and experience attentive listening? Great. Yeah. Encouraging. Oh, interesting, right? You felt encouraged to continue. Isn't that something you could use as a doctor with your patients? Yes. I'm sorry? You felt confident because he was engaged in your story. Nice. Yeah. Oh, no, but when you were the storyteller, I'm asking right now. Yeah. Okay, okay. You felt like you were a little worried about talking too much, maybe. Yeah. Did anybody else have that? Or it felt a long time to talk without somebody else chiming in? Maybe that's an experience you had. Well, when you were the listener, what was it like listening using only those skills and not chiming in with your own story? How was that experience? Yeah, it's okay. Not too uncomfortable. You guys are skillful at that. Yeah, yeah, you get to live in the person's experience. It kind of frees you. How many times has somebody been talking and instead of really listening to what they're saying, you're trying to think what you're going to say, right? That happens a lot in life and it happens a lot in medicine if we don't stop it, right? It's really powerful. We sometimes miss what the patient is telling us because we're thinking about what's the next question. But for this part of the interview, you don't have to ask a question. There's no question to ask. It's how can you draw the story out? So some of you felt maybe like 30 seconds was not enough time to tell your story in this way. And some of you felt maybe 30 seconds felt a little long. You wanted the listener to be more actively engaged. And that's fine. The same thing will happen with your patients. There's no hard and fast rule how long this step has to last, right? It'll be longer or shorter depending on who's in front of you. So step three, how do we know when we move from step three to step four, which we'll talk about in a minute, which is a bit more actively engaged? Well, it's kind of paying attention. You might notice that 3 to 4 seconds of silence doesn't encourage the patient to continue. And we talked about the fact that patients can stand that, right? Tolerate it. And if you've done it and it doesn't work, then something you have to try another tool. Whoa. Let's see. Sorry about that. Or the patient starts to repeat themselves, right? If they're plowing the same earth again, you heard it the first time. So we're wasting time here. All right. So if you've got a person who just repeats themselves, move on. Okay. Or the patient goes off on a tangent and doesn't come back, time is always limited, whether it's the hospital or the clinic. You don't have unlimited time. In psychiatry, they often follow tangents, but in medicine and most other specialties, we just don't have the time to see where this will lead us. So you need to use a different skill. All right. So that one of those three things will happen, and that lets you know that it's time to switch to step four. Step four is where you move from non-focusing open-ended skills, silence, nonverbal encouragement, and continuers, to focusing open-ended skills, which are echoes, requests, and summaries. So echoes are simply repeating the word or the phrase that the patient had said at some point during step three that you want to know more about. That's the key, right? So as the patient is putting things on the table, you're like, I need to know more about this thing, like this book they just put on, or this item they just put on the table. So you can echo that word or phrase that they put on the table. A request is simply echoing as a sentence instead of say the patient says, well, it hurts enough now, but not like yesterday. Well, they just put two things on the table. You could say, hurts enough now. You could echo that, and they'll tell you how it's hurting now. Or you could echo, not like yesterday, and the person will tell you how it was yesterday. Do you see how that works, how slick that is? Or you could say, well, tell me more about how it's hurting now, or say more about how it hurt yesterday. That's a request. Okay, same thing, same deal. And then summaries help. Let me see if I've got this right. So yesterday it was hurting more than it is today. And the patient will go, yeah, yeah, and they'll continue the story, if you see what I'm saying. So these are very, very helpful skills. So what you're doing in this step is you're lifting up off the table items that you would like to learn more about. You understand that? Does that make sense? And it might be a detail about the symptom story. I'll usually spin that out until the patient can't tell me anymore about the symptom story because it's the most efficient way to get the data I need. Or it might be about the personal context or the emotional context. Okay. So now let's do a little exercise Just given the time, yeah, we got time to do a minute and a half. Okay, so now with the same pair, you're going to get 90 seconds to tell a story of a recent challenge you've been facing. Maybe it's a personal challenge or some struggle in your family or some with a landlord or whatever it is, some challenge that you've had that you're willing to talk about, right? This isn't share or die, right? You don't need to share something that you really would rather keep secret. But think of a challenge and you'll get 90 seconds. And the listener's job is use those non-focusing skills, just like the activity we just completed, for 15 or 30 or 45 seconds, right? And then when there's something on the table that you're curious to know more about, use echo, request, or summary to learn more about that. What questions do you have about the task? After 90 seconds, I'll ring the bell. Speaker will become listener. Listener will become speaker. Okay? All right. Determine who's going to go first. Maybe the person who went first last time can be the listener this time. And stand by a second. Don't begin yet. All right. Are you ready? Begin. Okay. Switch roles. Listener becomes speaker. Speaker becomes listener. Go ahead. Okay. We'll stop and debrief this. So you each had an experience of telling the story of the challenge you're facing and listening to the story of your colleague's challenge. When you told your story, what was it like to talk about your challenge and experience reflective listening, hearing the words you put on the table reflected back to you so that you could deepen your story? How was that experience? A few people just shout out. Yeah. Okay, so you were maybe willing to go a little bit deeper in the story because your partner was demonstrating interest. Yeah. Uh-huh. I can see that. No. Any, any other thought, any other experiences? Yeah. Yeah. Right. And imagine somebody who's sick and maybe worried or frightened to feel listened to is so powerful. And how many patients, you maybe even have had family members who've had experience with the healthcare system, and one of their biggest complaints is they didn't listen to me. I never got to tell them how this was for me. It's actually in the patient satisfaction world, the number one complaint is she didn't listen to me. She didn't understand where I was coming from, my point of view. She didn't seem to care. So, wow, how powerful that this could be listening. Yes, sir. Whoa, acknowledgement without judgment. Yeah, isn't that encouraging and it removes any possible shame. Great. Now, when you had a chance to listen to your friend's story, what was it like limiting your vast toolbox of communication skills, since you've been talking since you were two or whatever it is, to six skills: silence, nonverbal encouragement and continuers as the non-focusing skills, and echoing requests and summaries as your focusing skills. How was that experience to be that intentional and mindful in your listening skills? So that's wonderful. Thank you. It made her reflect on herself and to try not to put in her own story. How many times have you been with a friend and they said, "Oh, where'd you go on vacation?" And you start to tell the story. "Oh, we went to Virginia Beach." And your friend says, "Oh, I went to Virginia Beach too. And we stayed at this hotel." Your friend just hijacked your story, right? We do that because it's a way of showing engagement, but really you just stole the person's story. Let them tell their story first, and then you can talk about your experience. I mean, you asked them the question, right? So we do that all the time, and if we're not careful, we do the same mistakes in medicine as we might do in our social world. So so helpful to have this increased awareness of the skills that you can bring to a conversation. And I will tell you that I am a much better husband and father since I learned these skills. It's honest truth, and you may find the same in your relationships, that listening better really, really works. Yeah. Okay. Did When you were listening to your partner's story, did your partner happen to mention how this problem was impacting their life? I see some heads nodding. So just like I said, patients often will spontaneously offer the personal context, how something's affecting their life. And did your partner mention an emotion, how this situation was making them feel? That happened? So it's a few heads, of several actually nodding spontaneously. You didn't have to say, how did that make you feel? They told you. Similarly, patients will often tell you how they're feeling if you just create the space for them to do so. Uh, so the goals of step four, just to recap, are to get the patient to say more about the symptom story using echoes, requests, or summaries. Make sure that you understand the personal context, right? Make sure that book that's put on the table by listening for clues, right? And and then lastly, seeing if you can get an emotion on the table. And as we've seen just in this exercise and what I mentioned earlier, patients will often spontaneously put the emotion on the table. But if they don't, we have to do a little bit of extra work. It doesn't mean that a patient doesn't have an emotion if they don't spontaneously mention it. To be a patient is an emotional experience, and any of us who've ever been patients know that. It doesn't mean you'll be necessarily crying. You just might be angry or frustrated, but nevertheless, those are emotions as well. Okay, so how do we get emotion on the table? Well, we talked already that the patient may spontaneously put the emotion on the table, so it's free. You didn't have to do anything to get it. But if not, you can read what you're seeing, right? You can read emotion. And we're going to talk on Friday, I think, about really how to deepen that skill of understanding what it is you're seeing emotionally in a person. You can ask them. It's fair to ask a patient how they're feeling or how that problem makes them feel. Or you can ask about how it's affecting their life, getting personal context on the table if they didn't put it there, asking about belief and asking about triggers. And I'll tell you what that means in a second. And lastly, you might make a guess or an intuition about how the patient's feeling. So let's talk about each of these. Reading the patient's emotion. You seem a little sad as you tell me this. You kind of offer it gently and see if you're getting the right emotion. You're reading the patient right. They'll acknowledge it or refute it, if depending. Asking about the patient's feeling. This is my favorite one, being very, what the anthropologists call emic, really kind of naive, curious, respectfully curious. Wow, how is this for you emotionally? Or how's this making you feel emotionally? I often put a comma with about three dots after. How's this make you feel emotionally? Notice the pause, the little catch there. And it's helpful to say emotionally because if you say, "How's this make you feel?" They'll like, "Well, it really hurts down here." They think you're talking about feeling as in somatic feeling rather than psychological feeling. Uh, you can ask about impact. How's this back pain been affecting your day-to-day life? Right? And the patient will often share an emotion in the telling of that story. You can ask about belief. People have ideas about what's going on, and it can be very helpful to uncover that idea, right? To help frame if they're really worried it's cancer, but you think it's just an abscess, you can really help the patient by removing that cancer worry from them. And then triggers. Why did you tell me why you came in today? You've had this back pain for 3 months. Tell me why you made an appointment at urgent care today. And you'll hear a story like, well, the guy in the office next to me has been having back pain and he just found out he has prostate cancer that's in his bones. Oh, so this person clearly has a belief about what's causing his back pain. And it's not the back pain that made him make an appointment. He's had it for 3 months. It's the worry that this back pain may signify that he's got something serious like prostate cancer too. So notice the power of understanding why the patient is coming to see you. Really, really powerful. All right. So, and lastly, and I think this should be the last thing you use. I think we've kind of outlined a hierarchy of steps, and this would be the bottom of the hierarchy. And that's to make a guess as to how the patient might be feeling. And if you're going to make a guess, use less charged or intense terms, like use the word upset instead of angry. All right. Use the word worried instead of scared. All right. And use the words might or could rather than must. So here's an example. I'm in watching a medical student interviewing a patient, and the patient has a coming in for a workup of ovarian cancer. And the student says, "This must be scary for you." Must be scary for you. So this person in a white coat is is imposing this emotion on this patient. And come to find out this patient wasn't scared. Now somebody medical is telling them they ought to be scared. So imagine how damaging that could be, right? Instead, if the student had said, "I could imagine this could be worrisome," you know, well, I call it floating it out on a lily pad, so gently offering it to see if they'll accept it or not, and not trying to impose it with the word must and using a really charged word. Another way to do that is, gosh, I think if I were going through this, I might feel upset. And then the person will say, yeah, me too. Or, no, I'm not so upset. I've lived a good life or whatever. They'll have their own response to you. Um, you can you can make a guess. I can imagine this could be frustrating to you. And they'll say, yeah, I'm frustrated, or they'll hone in what emotion they're actually feeling. But the challenge here is many patients are so deferential to doctors that they'll endorse the feeling you provide, even if it's not their feeling. That's why I don't like to use this as my go-to. This is like just my last ditch effort to get an emotion on the table. You follow my logic there. Okay. However you get emotion on the table, once it's on the table, there is a very important step to do next, and that's make sure you understand why that emotion is on the table. All right, why this particular individual is feeling this particular emotion. So, in other words, clarifying the emotion. So, it would be say more about feeling worried. Tell me more about why you're worried. Okay. Had a patient, a student interviewing patient who was having a manic episode, and the patient was young, the student was young, and the patient said, "Yeah, and I've run up what the heck? How did I think she said, but I'm really worried because I've run up all my credit card bills." And he said, "Yeah, I know exactly how you feel," because I think he had too. But he didn't really know exactly why she felt worried, right? So if he instead said, "Tell me more about the worry," is it financial worry? Is it I'm worried my dad's going to be angry at me? Is it I'm worried that I'm not going to get to be president of the United States because the person was having a manic episode? So it's helpful to just ask, help me understand. Those are some of my favorite words when I can't figure out what's going on. Help me understand. Three magic words, really powerful. Uh, and then once we do understand why this particular person is feeling this particular emotion, now and only now can we communicate empathy. Okay. Empathy is the ability of a person to to share understanding or communicate their understanding of another person's emotion. So it's your ability to communicate your understanding of another person's emotion. It's not sympathy where you kind of feel what the other person is feeling, right? Which could be draining. It's your capacity to say, I get it. I see why you're feeling that way. Okay. And we can do that non-verbally, as in this graphic, right? Leaning in, pausing the conversation, maybe using appropriate touch. Touch can be powerful, but it's also rather fraught. So you need to be careful how you use it. Your facial expression can convey a lot of empathy, right? If you're connecting with the patient. Eye contact, culturally appropriate eye contact is important. Some cultures, uh, and you don't want to use stereotypes or paint with broad brush, but strong eye contact is valued in some cultures, and it's not done in other cultures. New Chinese immigrants, I've been told, I've never asked one, but this is the lore out there, and also Navajo, Native American Navajo. Too much eye contact is not good. So tone of voice, softening your tone of voice can communicate paraverbally empathy. And closing the space, moving in closer to the person can communicate it. But what the research has shown us is nonverbal empathy alone is often not enough for the patient to feel it. When patients are scared because they're sick or they're in pain, their emotional intelligence score goes down. So if in order for you to help them see your empathy, you need to up your game so that it gets through. Okay. And the way we do that is to respond with verbal empathy. Right. And I want to teach you a mnemonic that when I first read it, I thought, oh, this is so hokey. I don't want to be scripted, but I use it all the time in patient care and in family care and in the checkout line with a set, customer in front of me or whatever. And it is so, so powerful. So we nurse the emotion, name, understand, respect, and support. And it sounds like this. Naming is really renaming the feeling the patient put on the table or you got them to put on the table, right? So you say this knee pain makes you frustrated. If the patient said frustrated, you use the word they used, right? Um, understand, boy, given what you told me, I can see how you'd feel that way, right? I tend not to use the word understand when I'm saying I understand how you feel, because some patients will say, you don't understand me, you're not living my life. But given what you told me, I can see how you'd be feeling that way, always goes down well. uh, Offering respect for the person's plight or for their strength or both. Wow, this has been a tough time for you, for example. Okay. And then offering support. Look, let's you and I work together to see what we can do. Right? That is such a powerful thing. What I love to do is watch the tips of my patient's shoulders when I nurse their emotion. And this is what I see. The tension goes out of the trapezius muscles. I've lifted their burden off their back a little bit. And this is where patients sometimes will cry. And you'll have to get used to that if you use this. But you're not making them cry, you're letting them cry. This has been pent up. In fact, when I'm in clinic, I always check the rooms I'm using, and it was never to see if I had enough tongue depressors or, things like that. It was always to see if I had enough tissues, right? Because patients will cry. And then you worry, oh my God, there goes my day. The patient's crying. Crying actually shortens the visit, and we'll show you how in a minute. So this is the story of the biopsychosocial model and how why it's superior to the biomedical model that really has been practiced since the early 20th century and sadly still is hanging on, even though I hope it gets transcended by the biomedical model sometime soon. Patients present with a symptom, and for many decades, doctors thought that was their only job: diagnose the symptom and treat it. But we know that there's more to their story than that. Patients have a personal context to the symptom. Symptoms affect lives in certain way, and it's important for the modern physician to understand that. And deep to that is emotion, right? To be a patient is an emotional experience. Almost everybody has an emotion about their illness. And if we can peel that onion down to the emotion and empathize with that emotion, we are doing serious medicine in real time. We are creating healing in real time. And I all I can say is try it for yourself. My own experience has been so powerful. As I mentioned yesterday, patients say, "Oh, I feel better already," or "Wow, no one's ever listened to me like that." I mean, really powerful statements, and it happens all the time. I'll just share a super brief story. Uh, I saw a new patient shortly before I retired. He was a 52-year-old African American man from North Carolina who'd recently moved up to Connecticut. And when I came in the room, his arms were crossed, and that I understood that. Here I am, a white guy. I know about Tuskegee. I know about all the stories of racial and medical injustice in the United States with African Americans. So I was totally prepared that I'd have to work to show that I was going to be a different kind of doctor for this guy than what he was expecting. So I used these skills. And at the end of the visit, two things happened. One, he was overdue for colonoscopy, and initially he said, but at the end of the visit, he said, I'll get that colonoscopy. And then he said something else that almost knocked me over. He said, Doc, I feel like I've hit the lotto. And I was like, whoa. He said, I've never had a physician in all my life with all my health issues listen to me like this and treat me as a human being. So that was a powerful moment. And here's the thing: at age 52, he had his first colonoscopy. He had a stage 3 sigmoid adenocarcinoma, but had a complete resection with clean margins, has been done fine since. So probably saved his life. He saved his life, right? I didn't make him have a colonoscopy. He decided to, but the relationship allowed it to happen. So that's just one story. Okay, so how do we get out of this? Oh yeah, before we talk about that, remember I said yesterday that this looks like it's going to take you more time, but I promise you it'll save you time. Here's just one example, and the literature is rife with these stories. This study audio taped visits in surgical clinics and medical clinics and coded the interviews. And if a patient expressed emotion or gave an emotional cue, they coded whether or not the physician responded to that, all right, empathically. And notice what happened. If the physician made an empathic statement, the visit was shorter than if the physician didn't make an empathic statement. Now, in the rest of your life, to do something takes time. How come doing something saves time here? What might explain this data? What do you think could cause this? Anybody have an idea? A big pardon? They may reveal more information that gives you a clue as to what's really going on, certainly. Yeah, it gets them to say what the doctor needs faster. This is what happens. If the patient says, yeah, I've just been kind of worried about this belly pain, and the doctor says, tell me, do you smoke cigarettes or drink alcohol or use any illicit drugs? The patient will say, yeah, it's really been bothering me a lot lately. And the doctor's like, well, in your family, anybody have high blood pressure? They're kind of going on with their list. The patient gets stuck and keeps dragging the interview, doesn't allow the interview to progress because they get stuck, right? But if you say worried, you just echo that. They'll tell you why they're worried. You can empathize with it, and then you and the patient can move on. So it's a way of showing partnership. Okay. So step 5 is super quick, but really important. It's basically to tell the patient, the interview is going to look different from here on out. Okay. The students who just started in January, I don't think you've learned yet about all the things that you need to ask in the history of present illness, past medical history, social history, family history, review of systems. It's a lot of closed-ended questions, okay? But what I'm asking you in this model is to save those questions until after step 5, all right? And it actually begins with step 6 in the book. So you might summarize what you've heard briefly to make sure you got it right. But most importantly, you want to let the patient know this is going to look different from now on. I'm taking the reins of this buggy, is basically what I'm saying. Okay. Um, and then you continue with what we call the middle of the interview, where you're going to use those doctor-centered skills. So let me just show you what this looks like. I'm going to ask Jordan to come back up, and we're going to do the same encounter that Jordan and I demonstrated uh, yesterday. We'll start at the beginning, but instead of stopping at the end of step 2 when we've developed a shared agenda, we're going to continue on to steps 3, 4, and 5. If you have the pocket cards that you received, take a look, follow along, and see if you can identify the steps of steps 3, 4, and 5. And I do think Dr. Alina sent an email with the PDFs of those cards. Not yet, so pull out the pocket cards. Great. Okay. All right. So just as a reminder, uh, Jordan, Mr. Mears, is the patient of Dr. Jones, my colleague, who's on vacation, and he's coming in as a rather urgent care visit. My nurse told me he's got some ankle pain. Okay, and that's all I know, and we'll take it from there. Okay, and I'll time this. Just yeah, I could do it here. Sorry. Okay. And you'll see me looking at my watch. I would not do that in real in real life. That's a real way to communicate that you'd rather be somewhere else. Which is not the case. I'd rather be with Mr. Mears. Okay. Knock, knock, knock.
Come in.
Hi, Mr. Mears.
Hi, yes.
Hi, very nice to meet you.
Nice to meet
I'm
you.
Dr. Auguste Fortin. Here's my name badge. I know it's not a very usual name.
Thank you.
Yeah, I'm a partner with Dr. Jones, who I know you usually see. He's on a well-deserved vacation this week, so I get have the privilege of seeing some of his patients. So happy to meet you. Yeah,
Nice to meet you.
yeah. Are you comfortable sitting there, or would you rather sit on
Yes.
the exam table?
Yes,
You're
this is
okay?
okay.
Okay, great, great. How was the trip into the clinic? I know they've been doing some road patching out in front, and it was kind of a mess yesterday.
It was a little troublesome, but I made it safely. Thank
Good,
you for asking.
good, good. I'm glad to hear that. Well, listen, we've got about 20 minutes together today. I see from Dr. Jones's last note that we should talk about an immunization, which I'd like to make sure we have time for at the end of the visit. And my nurse told me that you came in with some ankle pain, so I'm definitely going to want to hear all about that. But before we talk about the ankle pain, was there something else on your list that you were kind of hoping to talk about at this visit together?
Yes, I actually would need a doctor's note for work.
That sounds important. Definitely, we could do that. So we've got the ankle pain, the doctor's note, and the immunization that I'd like to make sure we have time for. Um, Something else on your list?
Actually, if it would be possible, could I have a refill on my asthma medication?
Sure. Okay, so we've got the ankle pain, the doctor's note, the immunization, refill on asthma medicine. That I think we can manage all of that in the time we've got available. Is there something else on your list?
Yes, I'm just a little concerned with the ankle pain.
Yeah. Well, why don't we start there?
Yeah.
That sounds important. Uh, Tell me all about this ankle pain. You start at the beginning and bring me up until now.
Sure. So I've been running for the past several years, and this is actually really close to me. So it's
Mm.
part of my life, and I'm just a little concerned of what would happen if I would be unable to do this anymore.
Mm, mm. So running is really important to you. Good for you for doing it. I mean, such a healthful exercise. Can you describe pain more for me and what happened to cause it?
Sure. So I was on a trail, and I was only out for about 5 minutes, but unfortunately, my right foot hit a rock, and I heard a bit of a pop,
Oh,
and I went down immediately.
oh my goodness. Wow. And what happened then?
So fortunately, there was some other people on the trail who were able to come by, and they were able to call the ambulance for me.
Oh
So
my
I
gosh.
didn't have to stand out there or sit out there too long.
Yeah. Oh my goodness. What an experience. Yeah. Sounds like this has been impactful to your life. Yeah.
It has, it has. So my mother actually goes running with me often. It's sort of a bonding thing we have, and that's contributing to my concern is if I can't do that with her anymore.
Mm. So that you're lucky that you're able to run with your mom. I could see why that would be concerning. You mentioned that this is concerning for you. Could you say more about the concern that you're having?
Yeah, so the main concern is that I would love to continue to run, but also it would impact my job as well. So that's really why I'm interested in getting the notes so that I don't get in trouble in my work.
Great. Well, that makes perfect sense to me. It's a hard thing to not be able to do the thing you love, and I also want to make sure that you can, not have your job in jeopardy. Great. Well, let's work together to try to figure out what's going on with this ankle and what we could do to get you back on your feet, so to speak. Does that sound okay?
Wow, thank you so much.
Oh, you're
Yes,
welcome. So if it's okay with you, what I'd like to do is shift gears. I've got a few questions I want to ask you to better understand what's going on there, and then we'll do a physical exam of your ankle, and then we'll talk about the asthma refill medications, the shot that Dr. Jones would like you to get, and I'll make sure you get a note for work. Sound okay?
perfect.
Okay. So 4 minutes and 1 second. Okay. So notice for those of you who are older students, not chronologically, but just here at Axon, and know the questions that you have to ask about onset, position, quality, radiation, severity. Notice how many of those questions I don't have to ask now because I have a decent understanding of what happened. Yeah, I might need to ask on a scale of 1 to 10, how severe is it? But I got a sense. I mean, he couldn't walk initially, right? And obviously, I'll ask more questions. Were you able to walk after? How did you get in here? Those kinds of things that you might have been wondering about, but I have fewer questions to ask, which will shorten the visit. Now, Jordan, I know this is totally simulated and fake, but how was it for you to share this story that's not even really yours, but to experience empathy that hopefully felt genuine because I was genuinely
Yes.
engaged with this story.
It did felt genuine. It was better because it was a back and forth. There was no awkward moments where I felt like you weren't understanding what I was saying, but then also you allowed time for me to really say what I needed to.
Right, right. And for those of you observing, what are the skills, silence, nonverbal encouragement, continuers, echoes, requests, summaries? What skills did you notice? Nodding. Yeah, lots of nodding. And I leaned in,
Mhm.
right? Yeah, yeah. Um, and I had an open posture. I wasn't like,
Yeah.
like this. Yeah. Good. I nursed his emotion, right? Yeah. And notice how smoothly it goes. And what I love about that order is that once you say the support statement, once you say, I'm here with you, we're going to work on this together, it's the perfect time to then say, if it's okay with you, I'd like to shift gears. I've got a few more questions to ask. And it's always okay because this person just had a chance to share their story and to experience this emotional connection, right? And then I can totally ask, you know, whatever questions I need to ask to understand the diagnosis and the rest of his health. Okay. So tomorrow, well, first of all, Jordan, thank you so much let's give Jordan a round
Thank
of
you.
applause. So tomorrow, what we're going to do is give you a chance to practice using these skills in groups of three. So as you come in tomorrow, try to find two other people who you can sit with and sit in the auditorium in a place where you'll be able to have a conversation without too much noise pollution. So you tomorrow we can spread out a little bit more, but I appreciate you being closer to the front. Isn't it funny though? Like nobody ever sits here. It's kind of like church. You have to come in late to get a space at the front. Yeah. Oh, the camera. Oh, okay. Sorry. Thank you for letting me know. Um, So tomorrow we can spread out. I'm going to hand out some case scenarios, and you'll have a chance to be the interviewer, the doctor, the patient, or the observer coach. And we'll see how many rounds we can do, but with any luck, we might get 3 rounds done. And then I'll talk to you about some special considerations where we might need to modify this model because of the certain characteristics of a patient. Okay. So thank you for your attention. Have a great rest of your day. See you tomorrow.